Welcome to Cardiovascular Medicine Grand Rounds. I'm so happy to see so many people here. A couple of announcements. One is that the CME credit system is changing, and the first day is today, so there's some emails that have come out about how to get your CME credit. Also, we're really happy with our produce station lunches. It's been really wonderful, but there's a lot of cardboard. So if your cardboard is clean and not soiled, if you can flatten it and put it in the recycling boxes, that would be great. Next week, we have Kevin Ward talking about critical care, and that'll be a really exciting talk. Today, I'm thrilled to announce the Matrix team. And I don't know how you came up with that title, but it's so cool sounding. So these wonderful leaders really need no introduction to our crowd. Matt, Stan, Dan, Steve, thank you so much for being here, and we're really excited for your talk.
Well, thanks for having us. Normally, I operate all day Thursdays, and I normally don't come to this. I had no idea that there was lunch. So these are our disclosures. And I think this is really an exciting time in cardiovascular medicine in that a lot of therapies are changing over from wide open surgery to less invasive to percutaneous therapies. I'm just gonna, every valve talk has to start with a little talk about the guidelines. I will show you the guidelines of how a patient comes to valve surgery right now and why surgery is gonna change over. And in every field that happens, a technique that has taken me 33 years on the faculty to learn how to do will be replaced by a technology. So one of the most important things at the last guidelines was that mitral regurgitation is not the same thing in all patients. So the disease on the left is degenerative mitral regurgitation. That's a disease of the valve. The disease on the right is functional mitral regurgitation.
Has started.
The valve is completely normal, but the shape, the size of the ventricle, the patient's had an infarct, lets the valve leak. Now, both of them result in mitral regurgitation, but they are totally different processes, totally different patient populations, and should never be thought of in the same way. It's like this: skin cancer and pancreatic cancer. Which one would you rather have? Well, you'd rather have skin cancer. And if you saw a paper that had both skin cancer and pancreatic cancer in the same paper, you'd say that's ridiculous, even though the word cancer is there. So these patients, even though they both have mitral regurgitation, are completely different and never should be thought of the same. Then we'll start about degenerative mitral disease. This is a patient who has a floppy mitral valve, myxomatous disease, and you can see that the natural history of this is actually pretty bad. Most of the patients by tenure are dead or have had heart failure or something disastrous happened to them. And what is it that gets a patient to surgical therapy? Well, there's a complex ACC guideline, but it basically breaks down to one of two things. They either have symptoms, meaning they should go to surgery, it's probably too late at that point in time, or if they don't have symptoms, what gets them there? Well, let's look at symptoms. Symptoms equals a bad outcome. If I operate on somebody who has symptoms when they have degenerative mitral valve disease, that's too late. We've lost years off that patient's life because by the time the heart has now worked 50% overtime, 100%, 200% overtime, and then the patient gets symptoms, that's too late. That is the last thing that happens. So symptoms, we do not ever want to operate on a patient for symptoms. Well, if they're asymptomatic, what are the guidelines tell us to move forward to an operation? The way to think of it is 60-50-40 AF. 60 ejection fraction, pulmonary pressures of 50, LV end systolic diameter, what the heart can crunch down to in AF. Well, let's look at that. If we wait until the EF is 60, that's bad. You can see we have clipped 4 to 5 years off a patient's life if we wait the EF to 60, because the EF minus 60 right now, but if I had severe MR, it would mathematically go up into 75 or 80. By the time it comes back down to 60, it's too late. Okay, well, that's a terrible guideline. What about PA pressures of 50? That's pretty high. And if we wait till the PA pressures hit 50, we've lost 7 years off a patient's life. How about wait until their LV can crunch down to 40? Remember, your LV systolic diameter is as big as your thumb and forefinger. So mine, I can get it down to about 2.4. 4 is that big. If my ventricle can't get down to that big, I've really hurt my ventricle. All right, that's a terrible guideline. And here's the one I like the best. I'm just going to buy a show of hands in here. Who wants to have atrial fibrillation? Yeah, so I've done that, like in big lecture halls, and we have those little clicker things. 10,000 cardiologists don't want to have atrial fibrillation. So why do we let our patients have atrial fibrillation? Especially because when we operate on them, we lose 8 to 10 years off their life because we can't get them back out of atrial fibrillation. So let's review. Okay, if we wait till symptoms, that's bad. If we wait till 60, 50, 40, or AFib, that's also really bad. Why are our guidelines so silly? Why? Why are they so silly? Well, the answer is, if you look at this, early surgery is way better than medical watchful waiting or whatever we do for these poor patients, waiting for them to destroy their heart. And if we repair and we do well, we cure mitral regurgitation. We put them back to the same survival in that group, whatever age they are. If I operate on a 30-year-old or a 90-year-old, I'm going to put them on a same population slope if I repair it. That's the problem. You can see as soon as I put a replacement in, they're on a different slope. And the guidelines say in your institution or with your surgeon, you should have a 95% repair rate. Who knows what the repair rate is in the United States right now? For degenerative mitral valve, it's 57%. So that's why those guidelines are so late, so lax. Our repair rate here at Michigan is 99.4% repair for degenerative disease. And so that's why we do so many mitrals here, because we can cure the patient of the disease for degenerative disease. And you can see it's basically the surgeon. This is a dot plot of every surgeon in the United States over a 3-year period. See that dot right there? That's me. But every surgeon is a dot. There's a lot of dots. We do know that. But it really turns out the more you do of something, the better you are at it. That's not astounding. And it turns out there's a lot of studies, the Virginia Cooperative, the New York Cooperative, all turns out it's by how many you do as a surgeon. So beware the patient-surgeon mismatch. If you have a patient with degenerative disease, you have to be aware of that. And these are my guidelines. Find a good surgeon. Think early repair, because even if you wait for the guideline indications, you're clipping years off that patient's life. So you got to get a repair. If your surgeon advises replacement, I advise you to replace your surgeon. That is the guideline for degenerative disease. Now, functional disease is a ventricular problem. This has nothing to do with the valve. This is the ventricle has changed its geometry, and the closure cylinder, the zone of coaptation, can no longer form. This patient has a myopathy. The mitral valve is fine. It's an innocent victim of this. Most commonly, we see it in ischemia. A patient has an inferior wall infarct and drags the papillary muscles out to the side. The mitral valve just can't close. Now, these patients are different. No matter what I do, what we do, we can't really get them back on their life course. They've had an event. They've had a heart attack or two. They're not like degeneratives. But FMR makes you die. There's no doubt that if you have heart failure, you're going to have FMR on top of it, you're going to die more quickly. It's not just a marker of a disease process. So we started doing undersized mitral repairs, thinking that if we would fix the mitral valve from leaking, then they'd get all better. Well, that was sort of naive of us because they have an underlying bad process. They're not normal. If I fix the valve, they still have 99 other things wrong with them. And we were like carpenters, and we only had one tool, which is an annuloplasty ring, and so everything looked like a nail to us because we only had a hammer. But we weren't getting rid of FMR. In many of the series, we don't get rid of FMR, and this is the key to success for these patients. You can see in this series from the Cleveland Clinic, they had a 40 or 50% recurrence of significant MR at 1 year. So you can imagine that'd be like taking 100 patients with colon cancer to the operating room, have 50 of them just leave the tumor in there and do nothing to it. You'd be very confused about whether operating on colon cancer is a good idea or not. So if 50% of the patients you operate on, you do nothing for, it spoils the broth. But there are studies out there that show a good effect. This was the first one. This is a randomized trial from Italy. Basically 100 patients who had coronary bypass with functional mitral regurgitation. Half of them they put a ring on, half of them they didn't. So think of it this way. Half no ring, half Beyonce. They got put a ring on it. So the ones that they've Beyonce'd over here, only 3% had recurrence. So think of those numbers. The no Beyonce, 63% still had pretty bad FMR, and the group of the ring did better. This is an English trial. Same kind of trial, no Beyonce. The Beyonce, you put a ring on it, they only had a 4% recurrence. That number's pretty low. That's good. This trial was stopped early because it was so positive, it was thought to be immoral to continue the trial. They said, you got to put a ring on everybody. No one trusts European trials. Who would? So we did an American trial of our own. This is the famous one in New England Journal. This is Mike Acker's trial. We said, well, look, if it's the MR, let's just compare repair versus replacement. So we looked at that. Everything thudded in, mortality, cardiovascular events, functional stats, all the same. It didn't make any difference in this trial. That was really disappointing and went against other trials. What was different was in the repair group, already at 1 year, a third of them had significant mitral regurgitation. And at 2 years, 50% had significant mitral regurgitation. Again, spoiling our concepts about it. What was really interesting in this is all the patients started at 67 millimeters. So these were giant, awful, ugly hearts. And if we did a bad repair, they only went down to 63. No one was saying a bad repair is a good idea. Bad repair is a bad idea. The replacements, even though we got rid of all the MR, they didn't really remodel. They went down to 61. It was mathematically significant, but biologically insignificant. If you had a good repair by accident, you remodeled down to 46. So a good repair with sustained abolishment of mitral regurgitation is what patients with FMR need. The problem with surgery for these patients, if I get a good repair, I'm great. But if I don't, if I miss, I default down to a bad repair. That's a problem. That's a problem. Then I have to reoperate on the patient or do something else to the patient. So surgery itself for FMR is not magic. Percutaneous, we'll see, is not magic either, but residual FMR for these patients is tragic. If you leave them with FMR, it doesn't help them at all. So here's what we think about degenerative FMR. Find MR, find the right surgeon, and fix MR. Functional MR, find MR, fix MR. It has to be well. You have to have a sustained reduction in MR. And you can see that now with transcatheter techniques, we can treat more. 6 million people in the United States have mitral regurgitation of both FMR and DMR. And this year we will do 54,000 cases surgically. So 6 million have the disease, 54,000 are going to be treated. So it's less than 1% get treated. Transcatheter is now trying to replicate the gold standard. And it's going to have to be a toolbox approach. You think of it, the mitral valve is very complex. The aortic valve is simple. We replace it surgically. We learned how to do it surgically, yay. We learned how to do it on a catheter, yay. But it was sort of illogical of us to think we could take a TAVR, turn it upside down, jack it into the mitral valve, and that would cure everything. Degenerative, functional, everything. It's not. That's not what we've learned how to do it. And in fact, the gold standard for mitral regurgitation is more than one thing. When I have my choice looking at it, when Matthew and I are in there, we'll put a ring on it, we'll do something to the cords, and maybe if we can't do that, we'll default to replacement. So an annuloplasty ring, chordal leaflet repair, and replacement are going to be what we're going to learn how to do percutaneously. So we're going to have a toolbox, and the good thing about the toolbox is we will now not have to operate on heart failure patients. We won't be operating on the bottom of the list when we've let their EF go too low. We've let their PA pressures go too high. We've let them have AFib. Nobody in here wanted AFib. Why do you want to let your patients have AFib? And in fact, we're going to change it with percutaneous methods and look, instead of heart failure, we're going to go to heart success patients. That's who I want to intervene on when they haven't impacted their heart, and we can just send them on their way. And I think that's true percutaneous techniques are going to get us earlier patients. Matthew's going to now talk about the options, and these guys are all going to talk about the toolbox that we've now developed here in the Matrix program.
Well, good morning. I'm going to talk about chordal therapies to treat degenerative mitral valve disease. And what's really been nice about the Matrix program is it's been a wonderful collaboration, the two disciplines, to really offer patients, not just high-risk patients, but patients who have a class 1 or 2A indication for surgery. So even low-risk patients, medium-risk patients, we now can offer them something. So it's not just for high risk. So addressing the chords is nothing new. It's been around for quite some time. And the beauty of addressing chords is that you pretty much maintain leaflet integrity, right? So you maintain leaflet, and you're really trying to resuspend the leaflets by recreating the natural pathophysiology of the mitral valve. And this has been around for a while. This is what we do in surgery almost every day. So this, you can see right here, this is a P2, which you'll see in a second, which is prolapse. And here we're inserting surgically Gore-Tex cords to the papillary muscle. There's various ways that we determine the proper length of these cords to decrease the volume of the tissue. And this is a loop method with pre-measured loops. When we do this, obviously in surgery, we're doing it on an arrested heart static, and there's several ways that we try to estimate what the right length of the cord should be with the understanding of what, and that's the finished result, what is required to reduce the prolapse or flail. But what if you can do this on the beating heart in live time? And that's what's really nice about what the future is in store for us, is that you can avoid potentially using the cardiopulmonary bypass machine. You can still target the prolapsed or flail segment. This is all done by image guidance. And what it also allows us to do is real-time adjustment of the length of the cords under normal loading conditions to really optimize coaptation depth. So currently, there are two things out on the market right now that are in clinical trials, and this is currently in a transapical approach. So there's the harpoon device and the neocord device, which is what we have here. Again, this is a transapical device, and this is an animation of how this works. Through a small thoracotomy, the device is inserted in the apex, and then the device will then grasp the prolapse or flail segment, which you see here. This device has a fiber optic mechanism to confirm tissue capture. And then a needle is inserted through the marginal end of the leaflet, and then a Gore-Tex cord is inserted. And we can insert numerous cords. On average, we put 3 to 4 cords per patient. And then it is adjusted under transesophageal echo guidance, and the sutures are tied to the apex of the left ventricle. We're currently part of a multi-institutional trial. The pivotal cohort is hopefully randomizing up to 600 patients. And again, these are low risk to moderate risk patients with a class 1 or 2A indication. There also is a high risk registry. The study itself is a 1-to-1 randomization, like I mentioned, to conventional open heart mitral valve repair versus this neocord repair. I wanted to just go through a case presentation to show you how this device works in real time. This was our first patient. He was a 59-year-old farmer for Toledo. He had worsening dyspnea on exertion and the physical exam findings of a systolic murmur. His last TE pre-op showed the following results, and he was referred for surgical repair. This is his pre-op echo, and you can see that he has a flail P2 scallop with eccentric MR. And this is how we locate the apex. So small 4-centimeter incision, left anterior thoracotomy, and we put purse strings in the apex. A small incision is made in the apex. The device is then delivered through that incision. And again, the patient's not on pump, heart's beating. Then through TE guidance, the device is advanced across the mitral valve. You can see it coming up here on the 3D. And then what we do is we grasp the prolapsed scallop, so that's what you're seeing here, and then the needle's deployed as well as the Gore-Tex cord, and then it's adjusted under TE guidance. So you can see here, cords have been inserted already, but we have not put any tension on the cords yet, so you can still see the prolapse. And then under echo guidance, we adjust the tension on the cords through the apex, and you can see the nice resolution of prolapse. And here's the color Doppler. You see a really, really nice result. All physiologic is still, you can still see nice maintenance of posterior leaflet motion. We've respected the leaflet tissue. And this is the discharge echo. You can see the cord emanated from the apex here, and really a nice result. So this is one of the tools that we have currently today to address degenerative mitral valve disease without truly doing open heart surgery. Will this evolve? Yes. This is some data actually from a European study that looked at over 200 patients, and at 1 year, the results are pretty similar to open surgical repair. So what information we have right now from Europe is that this is a very doable and durable procedure. But is it the only thing? No, in the future, this will evolve to transeptal. This is a picture of the pipeline device, and it's a transeptal puncture. This is another animation of a different device, which is not playing yet. How do we get it to play? I push this again. Oh. Codec unavailable. Where there you go. Okay, so if you can imagine that through a transeptal puncture, so not even going through the apex anymore, transeptal puncture, a device will come through the through the valve, through the left atrium, insert an anchoring mechanism in the apex, as well as inserting a Gore-Tex cord into the leaflet. And then again, under image guidance, we can adjust the appropriate length of the cord to basically reduce the height of the posterior leaflet and resolve the prolapse and regurgitation. This also, both of them, whether it's the transapical or this, can be used for anterior leaflet pathology as well. So these are some of the things that we're able to offer these patients, and I think it's an exciting time as the repair category expands. And with that, we're going to go to edge-to-edge repair.
Good turnout. My turn now, Dr. Menees, for those who don't know me, but in addition to what Matt showed earlier about some of the other things that we're doing, the neocorridor, which we're certainly currently active doing, I got the option to talk about the other currently approved devices that we're currently doing in the Matrix program. Both FDA approved. One is the edge-to-edge or MitraClip, which most people are probably fairly familiar with now, and then also using current TAVR technology for valve-in-valve in the mitral position. We'll talk about that a little bit more. I didn't come up with the name Matrix, but I get to at least throw in some fun slides. I asked that we all kind of dress in black suits and sunglasses, but I couldn't get Dr. Romano in the leather Trinity suit. We can figure out we have to pick who's Agent Smith. But anyway, so MitraClip, I think most people have been fairly aware, is something that's been available to some degree now for the last 5 or 6 years. Ideally, it was really a bridge to the gap, something to bridge the gap between medical therapy and surgery. As we know, medical therapy is useful for symptom reduction and management, but does not alter the progression of the disease. And really, mitral surgery, as Steve really eloquently pointed out, is probably the only real option that reliably reduces the disease process itself. So between the surgery and the medical arm, there is really a gap, which is what MitraClip sought to fill. So currently, MitraClip is indicated for primary degenerative disease, basically in patients who cannot get a repair, those who are prohibited for surgery, which, according to Steve, does not happen. But on occasion, these are folks that are determined by our heart team to be at high risk or prohibitive risk for mitral surgery. And that includes that dot, which is Steve, which is with a experienced cardiovascular surgeon of mitral valve disease. As most people know or are aware, this is a percutaneous version of an older surgical technique called the Alfieri stitch, create a double orifice mitral valve. And currently, with the MitraClip, is done through a transeptal puncture and done under TEE guidance. There are some anatomic criteria that we look at. Those are changing with newer iterations of the device, typically coab zone, posterior leaflet length, and obviously degree of mitral valve orifice, but really calcification becomes another really kind of big component on who can get a clip and who may not be able to get a clip. This is just an illustration. On the left is the surgical Alfieri stitch. Looks, if I could tie a stitch, looks relatively straightforward and easy, and that's what we're trying to accomplish there on the right. As you can see on the right, there's a clip coming into Real-time under echocardiographic guidance, a clip coming in, grasping both anterior and posterior leaflets, in this case, ideally A2, P2, and you can see real-time reduction in mitral regurgitation percutaneously. This is also what it looks like fluoroscopically. We don't typically do this under fluoroscopic guidance. We will do it in the hybrid lab, but really, again, it's really TEE and imaging that's critically important to the success of this procedure. This is basically the clip being fished into place, grabbing the two leaflets, and then being very happy that it doesn't fly away on release. Most of the data behind MitraClip, especially in the degenerative disease population, came with the Everest trial. This was published in 2011 by Feldman and company, basically looking at really feasibility and then ultimately randomized data in degenerative mitral regurgitation patients. What was illustrative of this study was that it was not as effective as surgery at reducing mitral regurgitation. Of course, it was easier on the patient than going to the operating room. There was, in that regard, felt to have superior safety. What was interesting, though, is in those who got a significant reduction in mitral regurgitation, there's no change in mortality. They did have similar improvements in clinical outcomes such as heart failure and actually LV remodeling and reduction. This is basically a busy slide of that, as I showed. This is the freedom of mortality or lack of mortality with mitral clip edge-edge repair percutaneously versus surgery. Really no change in outcome as far as hard endpoint mortality out to 5 years. What you do see, though, which was very clear, was that not everybody got as good of a response. Clearly, it was not as good at surgery as reducing regurgitation. The curves, though, separate quite early. So if you did get a good reduction in mitral regurgitation, it was a durable result out to 5 years. And so really, some of this, I think, illustrates a little bit of the early technology adoption and actually technique, but I would say that at least feasibility-wise, there's some hope for durability and reduction of symptoms. Again, this is just showing that same clip, just showing if you take out those first 6 months, take out those folks who didn't get a good reduction the first time, that ultimately was potentially equivalent to surgery. Again, with reduction in mitral regurgitation in these patients who were otherwise felt to be high risk or prohibited of surgery, they also got similar to surgery reduction in mitral volumes and regurgitation. And the question ultimately, which I think is a question we're still asking, is how much regurgitation or how much reduction in that regurgitation volume is enough for changing clinical outcomes. It's never going to be or has not yet seemed to be as good as surgery, but in their patients who are high risk or otherwise not able, this was actually seen and is seen as having a nice option for patients that previously didn't have it. What was interesting is, even though this was essentially a degenerative population of patient, up to a quarter had functional mitral regurgitation. And based on that and widespread use in Europe and a lot of functional patients, the question was, if we reduce mitral regurgitation in this population, could we see an improvement in outcomes? And so again, getting to the different populations of patients, people started looking and really spurred on the trials for functional mitral regurgitation. This was a big year for the MitraClip. In August of this year, at European Society of Cardiology, the first functional study was, first randomized functional study was released to not a whole lot of fanfare. This was a French study, and which basically looked at was supposed to be a real-world population of clip versus medical therapy. Unfortunately, there was no difference between medical therapy and the MitraClip at 1 year, with mortality rates up to 22%. It was a high-risk population, it was a sick population, but while there were some symptom relief, there was no change in hospitalization, heart failure, or heart endpoints. As Steve eloquently put out, nobody trusts European trials. So CLIP was not to be denied, and only a month later, some people might have seen this headline, COAPT was released. And the COAPT trial was actually a trial we were fortunate enough to be participating in here. It was really a U.S. trial it was a larger trial of over 600 patients, and was then just released and presented at TCT just last month. Quite to some surprise, this was the headline out of the New York Times, and prompted a lot of phone calls and texts. And this is actually a picture of Greg Stone presenting the data at TCT. I wanted to point, this was kind of came off the end. I just wanted to note that this was what the reporter on site said, and so I hope that at the time, when I'm done here, I would get a similar audible gasp and applause, because that happens very frequently in trials. But it was really a surprise. Nobody had expected some of the results. There's my gasp. Not very Neo-like. So CAB trial, similar trial design, again, a sick patient population. What I think should be interesting, and we'll talk a little bit about the differences, but really it was guideline medical therapy, guideline-directed medical therapy. What was interesting about this trial is they actually included a heart failure specialist at the get-go from the beginning. Patients had to be on very maximally tolerated medical therapy to even enter into the trial. So I thought should be commended. And I think based on that, a lot of people were surprised to see what some of the results were. What this showed was a pretty remarkable, not only reduction in the primary endpoint, which was combined heart failure admission and death at 2 years, but actually showed a total reduction in mortality as well. And it was a pretty significant decline, one that I don't think anybody really anticipated. There was a nearly 50% reduction in heart failure hospitalizations after 2 years, with a number needed to treat of 3. And again, a mortality reduction, which has not ever been really shown in functional regurgitation before, may give us some insights into this disease. So this was really shocking, which is, you can understand why people were so impressed, and that's interesting. And left a lot of people wondering what was the difference between the COAPT and the mitral trials. What we see here on the left, unfortunately, is this is what the mitral trial primary endpoint looked like. Unfortunately, I don't know what's going on here on the right. Awesome. Oh, there it is. This is our primary endpoint of COAPT on the right. So what we see is that the controls are roughly the same. There's a highly sick population. Nearly 50% of the population within a year were either in the hospital or dead. And with the MitraClip in the COAPT trial, we certainly seen a significant reduction. So what was interesting is it at least looked like on paper that it's a fairly similar population of patients as the control arms are not terribly different. Some other differences that have since come out and trying to look at why maybe the French study was not as good is they did tend to have patients have less regurgitated MR, so less volumetric MR and larger ventricles, suggesting that maybe if you don't have that much MR or if your ventricle is too big and it's too late, then maybe you're not going to actually benefit. So there has been some talk that maybe again, we hate to get into, it's a foreign trial and they do a bit worse job. They have a lot of experience there, but there were some significant differences. If you were in the COAPT trial, you had a much less likelihood of having significant regurgitation at the end, and oftentimes included more clips and better long-term results and less complications. So we don't know where this is ultimately going to go. It'll be up to the FDA to decide. I think most people being skeptical, I think seeing this marked mortality benefit and reduction, I think is reasonable. It was a vigorous trial, and we were a part of it, and I think it was a difficult one to enroll in. I think they did a good job, and the question is going to be ultimately is, do we believe this data or not? Is it going to be paradigm shifting in how we approach and how we think about functional mitral regurgitation? So like most things, we'll find out. We'll wait for, there's a third trial becoming shortly called the Reshape 2 trial. We'll see if it's a tiebreaker or if it gives us more information or added information about what population of patients might most benefit. But we'll anxiously await and see where we go with that. I briefly wanted to touch base on valve-in-valve. For those folks who cannot get a good repair, there is another option, which is a valve-in-valve using, right at this point, dedicated TAVR technology for both stenosis and regurgitation of a failed bioprosthesis. There are no randomized data or trials at this point. Most everything is single center or small registry and observational trials. Generally speaking, this is a pretty heterogeneous population. They look at both valve and include valve and ring, and even in some places valve and calcium. Multiple different trials and multiple different devices have been used, both balloon expandable as well as self-expanding technology, although the vast majority are really using the balloon expandable Edwards sapien valve at this point. The access route has been multiple, starting out with transeptal using an apical rail to even a transatrial approach. Most places now are using primarily either a transapical with a large preponderance of folks moving purely to a transeptal approach, which is what really mimics what we're doing here. So again, not a lot of randomized data. In fact, no randomized data. It's all just single center data out there, most of which pretty much mimic the same, which is that it's feasible and usually a highly sick population. So a nice technique and a nice option for your patients. And just one small registry here, we had folks with all class 3 and 4 heart failure, all got better out to 2 years with a mixture of both stenosis and regurgitation using an Edwards sapien valve. Similarly here, we see a 90% 30-day reduction in death or significant mitral regurgitation. That's in a high risk patient population with an improvement in their stenosis. So this is a case that we just done recently. This is a gentleman who was felt to be prohibitive for a redo. He's already, you can see, has had his TAVR on this. This was our aortogram before we put in filters for what's called the Sentinel device to reduce any risk of embolus to the brain. This is us ballooning the septum from the IVC into the across the septum. This is the Edwards valve coming up through the IVC, and don't pay attention to that filter there thing that apparently stops clots, but allows our 24 French sheath to go through. This is our valve being positioned under rapid pacing. And that was actually it being deployed as well. This can be done under complete fluoroscopy. This rapid pacing, you see the TAVR in place. So now he has a TAVR and now his second valve here in the mitral valve position. And then the results here in the end on the left. Pre-new valve, post-new valve. So really limited long-term data and valve, but all the registry trials show really good short-term and intermediate outcomes, good procedural safety. We'll have to understand really what the long-term durability of this is, and with increased use of the transeptal route becoming more commonplace, I think it's going to continue to be a less invasive option for your patients moving forward.
So the first law of show business is to get the stars in the end, but today we've flipped it, because after those three, this is like the Feast of Cana. You get the bad wine in the beginning and the good wine in the end. I'm mixing my, tells you how unreligious I am. One more thing, I want to thank Melinda for inviting us today. Melinda, I will tell you one thing, though, in the future, when someone stupid like me tells you 4 of us can do it together, say it's not a good idea. Go talk to Stan. Because trying to get us 4 together to meet is like herding cats that are feral. And basically, we only met last night, and we're still doing slides half an hour before we came in here. So apologize if these slides are not really what you want to see. I get the easier task of looking into the future. And so the dictum is, when you have no data, show a lot of video. So with novel repairs, Steve was very, very eloquent in showing us how this is not a one hammer fits all. We talked about edge detection, leaflet coaptation. Matt was very, very eloquent also in showing us chordal implantation. These are some of the FDA studies approved and ongoing. Neocord, Matt spoke about. And then there are the annular plasterings, and I'll also talk to you about some valve replacements. There are 2 annuloplasty studies going on right now. Carillion, I'm not going to say much about it, and I think we have better options. There's Edwards Valtech Cardioband, which I'm going to show you here, and I hope this plays. Yes. I would have had to talk much more. So this is a transcatheter mitral annular reduction. It is not a complete ring reduction. It is a trigone to trigone. It restores leaflets to a more functional position. So again, transeptal technique. And I will stress again, and you've heard all of us stress this over and over and over again. The mitral space is an imaging space. Without imagers, without imaging, we are blind. And I'll also show this in the replacement. I use the analogy, we're like Sir Edmund Hillary going up to Mount Everest. The Sherpa was there many times before. The Sherpa has to tell you where to go. Otherwise, without the Sherpa, you are nothing. And here you can see, as you are going around the annulus and employing these devices, you anchor around the ring, and then and you can see this under fluoroscopy, but it's mostly done under imaging. And you go around trigone to trigone. I don't belabor this too much. But when you're done, you take out the first element that has done, and now you take a second element that cinches this running suture that is all around the annulus. And now you are going to really minimize the diameter. As you can see, you approximate more. Here you have the cinching tool, which pulls everything together. And you can see, as you tighten, the ring becomes more constricted, and the beautiful MR goes away. But this is, again, there is a newer technology, which we hopefully will be seeing soon. Boston Scientific has acquired this technology. And this is the first adjustable, completely retrievable transcatheter complete mitral annular plastering. What's also nice in this is the newer iteration. So this is, again, we've talked about the surgical standard, repair, annular plastering. The ring with surgery reduces annular circumference and septal-lateral diameter. So you can have primary MR repair, secondary MR annuloplasty, or you can have something that does it all percutaneously. Here again is a little video that shows the different elements. It is a very ingenious device. You have obviously a frame that gives you structure. You have what are called the anchors that are anchored into place under echo guidance again. The interesting thing about this is that echo has now also, they have incorporated an intracardiac echo element to this. So you don't even have to put a patient to sleep. This is done under awake, conscious sedation, no general anesthesia. Again, under imaging guidance, you get a good transeptal technique. Device comes in, and the newer iteration in the center of this will be the intracardiac imaging element that shows you exactly also with PD elements with the newer devices. You position this around the annulus exactly where you want. You put the anchors down. The frame is now in position. You can then cinch down on the frame, and when you, under echo guidance, you're happy with the amount of cinching you've done and the amount of MR you have reduced, you can unwind and release the frame. So here you see the frames being anchored in and then released. Here is what it looks like under echo with 2D. You can see how it comes down. There's a 3D element, which we play back and forth with 3D. Those of us who work with us understand this. And then you're going to see the device being expanded, opposing, and then being anchored. And here is we rarely use fluoroscopy. One thing, Matt even mentioned this. This is truly an imaging-based specialty. And it's the strangest thing going in to help Matt with a neocord, and we're not wearing lead in a cath lab. It is feeling very, very, very unsettling. Here's some early millipede data, and again, I'm not going to belabor this too much, but there's the first 9 cases, but you can see very clearly that there's reduction in septal-lateral diameter, and a reduction in LV volume is quite significant, and we're waiting for the study. But, although we initially always thought that the replacement was going to be a gold standard, we have modified this. TAVR was easy. And again, even though we've sort of rode that wave for a long time, you had stenosis, you treated stenosis, outcome was significantly better right away. With TMVR, it is way more complex, as Steve and all our colleagues here have demonstrated. All we worry about with TAVR is the annular size, leaflet calcification, have a size, get a size that fits it. With mitral valve, the annular size, the shape, the excursion, the leaflet size, the thickness, the tenting, the surrounding structures, including the coronary sinus and the circumflex artery, all are important elements that go into our thought process. And it's a dynamic environment. It is in close proximity to the outflow tract. So when we think of how to design a TMVR process, we have high expectations because we've lived through the TAVR era, and we have to mimic TAVR. So there are many complex steps in development. There's a proof of principle, which we still have to show. Evidence has to be built up. We have to update technology, and the widgets have to get better, and there will have to be a wider application. Just to give you the scope of what we're dealing with, this is a partial landscape of, with 6 million patients having MR, this is what and this is where the money is. If you want to understand where the technology is going to go, look at what venture capitalists are investing in. This is just some of the TMVR landscape. And just this is the list of ongoing US and outside of the US implant. We are very privileged here to have both Intrepid and Tendon as being two of the valves we're studying. And then I'll talk about these. But what are the challenges for a TMVR? The device is complex and large. And Maurice and Elena, who read echoes on Thursday, have had kind of a bit of a shock seeing some of these cases with big septal defects that happen because we implanted devices on Wednesday, and on Thursday I get multiple calls. You have a big ASD. That happens because you have a big hole in the septal, which usually tends to heal on its own. The device is complex and large structure. We have to understand the leaflet material, and the frame has multiple components. What will crimping do to a valve? We know from a TAVR standpoint that it doesn't do that well, that poorly. In fact, 5, 6, 7, 8 years, the function is still very good. The annulus, and how do we affect the annulus and the LV pressure loops, and interaction of these multiple elements with blood elements. I talked about the importance of imaging. Imaging is also critical in the pre-procedure planning. CT has become the bastion of planning a TMVR like it has for TAVR. A large valve size, we have larger closing pressures. It has to be anchored to the leaflet and is annulus based. And very critically, you can see how the LVOT and the new device can interact and cause an obstruction. So this is some of the newer ways we've done things. In the past, we've always thought of the annulus as a saddle shape, but our surgical colleagues understand this much better than we do. It's more of a D-shaped annulus. And this is all done under CT guidance. And here's a case we're implanting it actually next Wednesday, a week from yesterday, where we go to different surgical planning. Now, these new plannings, like Fremencio which is our measuring tool, has these different tool sets where you can implant one of the 6 or 7 valves currently available that you can implant, that you can sort of drop it into your image and understand what kind of obstruction you have to have. So you can see with this complex imaging, how important a good structural imaging element has to be in your implant. And you can see here's a potential Intrepid going in, here's our LVOT. We get these whole phases, 10% to 40% of cardiac cycle. And if your average is over 1.5, we prefer over 1.8, you're gonna have a good result and you have no significant LVOT obstruction. The Intrepid device is a two-component. There's a conformable outer edge and the bovine tri-leaflet valve in the middle. Because it's in the middle, hanging on within the outer frame, you only need to have one valve size, so it's easier for production. And it's a very interesting pneumatic release. So if you can go to stage 1 to stage 3, you advance it into the LA first, very similar to the way we advanced Neocord. You expand the brim and align with your annulus target. And as you come down, you retract, deploy the outer rim first, and when you're happy under rapid pacing, you deploy the target. So here is a case in point. If you can see, it's an apical incision for now, with pledges very similar to what Dr. Romano showed us. And here is this, what we call the finger poke technique. Although we say it's apical, it's not really the apex, it's a bit more lateral. So what we're doing with the heart exposed, one of the surgeons pushes, and under echo guidance, yeah, you seem to be in the right place, you have a good line of attack, go there. So the sutures are put in. And here you see, as respiration is held, so the importance of anesthesia and imaging and coordination, you see the valve on the left being brought down. When it engages the annulus, you deploy the first portion of it, and then you'll see towards the end, with rapid pace, here you go, the heart stopped, and now we're gonna deploy the second element. At this point, it's the point of no return, and don't wait too long, but there's the valve being deployed, and you get a new functioning valve. There's not much data, as I said in the beginning. Now I think the implant number is up to 89, I think, Steve, right? Last time we spoke with a So here, on the left graph, the bar graphs, you can see the implants and how long they've been followed so far. The ones in red, unfortunately, are the ones that passed away. And this is just the beginning. It's just to whet our appetite. As we think about the complete repair, ring and repair, here's one. I'm going to just give you a couple of examples. This is the Edwards Sapien M3 system, Doc valve and final implant. And here's another one which incorporates a ring and the valve itself, so it components two parts of the toolbox. And then the holy grail for this space in the TMVR space is a true transeptal where you don't have to do an apical puncture. So here you can see the complexity of having 290-degree bands, but again, it's possible, and we're hoping to have this in place. We're holding our breath because the companies are always very optimistic, but we think maybe by mid next year we'll have a transeptal Intrepid format. Now, just to put the device landscape, I showed you a ton of TMVRs. This is just in each element of the toolbox, edge to edge, coronary sinus annuloplasty, direct annuloplasty, MV replacement. You can see how daunting and overwhelming it is. So in conclusion, although extremely exciting, the path forward has to be thoughtful, circumspect, and under the auspices of all the stakeholders. The importance of a heart team with critical involvement of heart failure specialists and imaging specialists cannot be overstated. You cannot do these without all members of the team. The path leading forward towards device approval will be treacherous and fraught with struggle, and we have to persevere in this. The long-term durability and how these different options will fit into some algorithm with respect to the sequence of interventions and which ones you choose first is still to be determined. The training in all these techniques and the cost of combining these techniques, that Intrepid valve you just saw costs $45,000. A regular surgical valve costs $4,000. So just put things in perspective. However, like in every field in human history, technology will develop at an unremitting pace. It won't wait for anyone. And the victors will be those who adapt to it to best. Before we conclude, I wanted to I was going to put a picture of everyone here, but I would forget someone. And I would like to take the opportunity to have our members of the Matrix team stand up and so introduce yourselves. So Marianne and Marianne and our research element is up. So there is these guys do an unbelievable amount of work. They are basically, I call the brains of the operation and just point where we're supposed to go. There is a Matrix pager, so when you go online, when you go in our paging webpage, you can find a Matrix pager. We have also a clinic where the four of us see patients together in a Matrix element. One thing also I wanted to say is, when we designed the name Matrix, we thought it was a cool name. And looking at the audience and how young most of you are, I realized that the Matrix came out in 1999. None of these guys know what we're talking about, probably. So with that, I'll stop and invite you all to ask questions. You guys want to come up? Pardon? Oh, yes.
Stan, thank you so much for organizing this. It was a wonderful overview, and I really appreciate it, and I know everybody else did as well. So for the technical aspect of putting in a referral when we see patients in clinic, can you walk us through what we should do and where the patients should go at this point?
There is a Matrix consult that you can both for inpatient and outpatient. And Michelle just left. Surya, can you help me out? So basically, there is a consult you can request specifically for Matrix.
But for outpatient, there's no MitraClip referral that applies for inpatient because you have open procedure or anything like that. But as of right now, facilities and we should be getting that.
Yeah, so that's a good question. We really don't have anything effective for the tricuspid right now. We're going to begin tricuspid clipping, taking the MitraClip, but that just doesn't work. There are devices out there, like the Millipede device has experimentally been put in humans in the tricuspid. So I think there will be some, but it's going to, nothing right now. Diane? Yeah, that's a good question. Nobody knows what the right anticoagulation. Remember, the TMVRs that Stan showed have a huge footprint in the left atrium. And some of them, like the early devices, like the Fortis device by Edwards, they were having strokes. They started running their INRs at 5, and they were still having strokes. Because if you think of the actually square centimeters of surface area of devices like that, they got flanges and hooks and pericardium and something like that. So that's a problem. So right now, we're running ours for 90 days on Coumadin unless there's some other indication for or against Coumadin in the patients. Nobody knows if that's right or not. Other questions?
I was wondering if you could touch on your experience with special populations like patients who have had endocarditis or patients who have connective tissue disorders like Marfan's and such.
Had endocarditis, and what was that thing?
Patients who have disorders like Marfan's, for example.
Yeah, so these devices haven't been used in endocarditis. I mean, in some of the patients we've done, so the valve-in-valve, we've had a couple patients who've had endocarditis in a bioprosthesis, then was probably cured, then we put a valve-in-valve in. Remember, it's not, the problem with these devices, there's 47 different types of devices and 147 different types of patients. That sets up a really big matrix of what we have to do. See how I worked that in? Yeah. So I don't know the answer yet.
Comment about the dimension of the LV. What's the highest size you would be willing to work with?
So obviously the LV size and the LVOT are something we're super impacted on, especially in the TMVRs. If you can think of it, that again, that's the size of my mitral annulus, and I'm pretty tall. Those Intrepid devices are 42, 49, and 51 millimeters across at the annulus. Because as opposed to a TAVR where we're using radial force against a calcified annulus, this is mostly in functional mitral regurgitation. As you expand that annulus, it just keeps going. So that's why Stan, I think, said the word imaging 114 times. That's why it's all about imaging, both CT and more importantly, echo in the mitrals to see the size of the LV, the size of the resultant LV overflow tract. It's a really important thing. We've done patients, Stand-in, we didn't talk about it much, but we've done valve and MAC cases. So de novo, they have solid MAC, they're not very good surgical patients. And we did one where we did all the calculations and so on like that, and we put an upside-down TAVR in it, and we ended up with a outflow tract gradient of 125 millimeters of mercury. That seemed high to us. So that was a true hybrid patient because it was a hybrid between completely non-operable to, yes, now it's operable, boom. So we operate on that patient, but
Answer your question.
Really important.
One element of this space is also, as we get more facile with all the different technologies, if the ventricle is too large, if you can put a ring in it, and then use that ring you've put in as a frame for a smaller valve.
That's been done.
That's
the
being
one
done.
device that I'm familiar with, the millipede device there, is reverse of a TAVR. If you think of a TAVR sits in the valve and pushes out, millipede actually goes out and grabs the annulus and comes in. Once it's in, it comes down to a 27 or 28 or 26. Then it has been, in those patients, if it fails, then you can mount a very small valve in there up into the device itself. So that's another thing that's going to be done in patients.
I want to congratulate you guys for developing this team. I think what we're looking at here is the future of cardiology, and this is what we need to be doing.
Well, I think it is too. It's been fantastic learning from these guys. I mean, I'm ashamed to say that I have my own lead now and with my name on it, and I actually know the names of the wires and stuff like that. And
Almost.
Almost.
You have codes for everything.
Question back there. I have my own name. Yeah, that's your problem, not ours, The answer is an apical puncture is going to go away. This field will never develop in that range. It's usually a step for us. Apical puncture, I'd say 5 years from now, we will never do it again. And all of these devices will be transeptal. We're already seeing that we're going to transeptal. This is part of the transition. It's only going to be effective if it's transeptal. Yeah, you'll see these 24 that we've done, or
But to answer your question, there was a vast transapical experience in the early TAVR days. And that, although they were dying from the comorbid conditions, there was no higher incidence of sudden cardiac death. They were dying from the acute event, because the insult to the apex, but there was no higher incidence of VT of complex arrhythmias afterwards.
But this field will only move forward as transcept. Everyone, surgeons, cardiologists, everyone agrees on that. This will not be a transapical field.
Just like transapical TAVR is a dead specialty.
At all. Anyways, thanks everybody for coming today.